Hello, today is our next lecture. It's about diphtheria. Diphtheria used to be a big problem in previous time. Then, due to vaccination, it's almost disappeared, but then due to anti-vaxxers and migration process, it may be a problem again. In the countries where people are unvaccinated, it's still a problem. So, diphtheria is an acute infectious disease caused by toxigenic strains of Corynebacterium diphtheria. Pay attention, toxigenic. There are untoxigenic strains that is not dangerous. It's anthropognosis, so the sources of infection are humans, characterizes by a development of fibrinous inflammation in the place of entry and remote effects resulting from toxin, which affect the heart, kidneys, and peripheral nerves. Diphtheria means membrane or leathery skin. Historical reference. As the disease came to Europe from the east, it has long been called the Egyptian plague or Syrian ulcer. Some manifestation of the disease in the initial stage of its development calls ulcers, throat angina, pectoris, or throat plaque. In the 18th century, the disease began to be called croup. A detailed description of the clinical disease was given in 1826 by French physician Pierre Breton. He first pointed to the relationship of lesion of the larynx with croup, its inflammatory narrowing, and called the disease diphtherit. Later in 1946, internist Trousseau suggested the term diphtheria, which applies now. In 1983, Klebs discovered the pathogen in diphtheric films and described it. In 1984, Loeffler identified the causative agent in culture and described its properties. In 1888, Rowe, Yersin, Bernick secreted exotoxin and antitoxin, and this was the beginning of specific therapy of diphtheria. In 1923, Glenn and Ramon secreted adatoxin. It was beginning of massive immunization against diphtheria and leads to significant decreasing of the incidence of cases. Etiology. Corynebacterium, from Greek korun, club or mace, bacterium, small rods, consist of a diverse group of bacteria including animal and plant pathogens as well as saprophytes. Scum Corynebacteria are part of normal flora of humans, so if in the throat swab there is found just Corynebacterium, it not necessarily means that person's health are in danger. So you need to wait not only bacterioscopic examination, but also bacteriologic to confirm that this Corynebacteria is toxigenic. So Corynebacterium diphtheria, gram-positive thin rods, club-shaped, monochromatic grains of volatilin in the end of rod, non-motile, non-sporulating, has no capsule, selective aerobe, it's rather large. So here you can see how it's look like. Etiology. Still has fibrous, phosphating and adhesion, divided by flakes in medium and is seen in a short chain V or Y conformation or resembling Chinese letter. Grown on complex nutrient media containing serum, Loeffler's broth, or blood agar with tellerite, Clover medium. Optimal temperature for cultivation is 37 degrees. Stable to low temperature, sensitive to boiling, disinfectants can be inactivated in 1-2 minutes, can survive in room temperature, in water, in milk, 1 to 3 weeks. There are 3 biowares of Corynebacterium diphtheria. Biotypes are different by colonization morphology, fermentation reaction, enzymatic abilities, and severity of the disease. Gravis R form causes the most severe form of the disease. Metis S form causes disease in a mild form. Intermedius, intermediate from between and above 2. Again, how it looks like under the microscope. So one of the important parts of its pathogenesis is that these bacteria produce exotoxin. Pathogenicity depends on the presence of the Tox plus gene carried by a lithogenic bacteriophage. Cases of non-toxigenic strains of Corynebacterium diphtheriated also has been documented. Produces aggressive enzymes, different attractive biological substances like hyaluronidase, neuraminidase, fibrinolazine, hamilazine, necrotic and hydrotropic factors that promote the action of the differential toxin and spreading of Corynebacterium. Diphtherial toxin is polypeptide composed of two jointed segments, A and B. E is actual a toxin that inactivates RNA translocase and inhibits protein synthesis in the cell with a subsequent death. B recognizes the target cells, binds to their receptors, and facilitates the entry part A. Toxin is in unbound condition in the blood during 10 minutes and next 30-40 minutes fixed on the surface of the target cell. Then diphtherial toxin penetrates the cell. It couldn't be bound by antitoxin. That's why it should be early administered antitoxin. Don't be slow in case of diphtheria, it saves lives. In diphtherial toxin is on the third place by action. First, botulism, second, tetanus. So still rather strong toxin. Again, and how this toxin looks like. Again, a bit of pathogenesis. When unbound diphtheria toxin binds to subunit A, and then as the toxin protein synthesis go into cell. Again, A and B diphtherial toxin, B connecting to the cell membrane, and A inactivates elongation factor 2, prevents protein synthesis by ribosome, and causes cell death. One of the methods of diagnostic, mostly not used right now, but still present, a wireless intradermal test in rabbits. 2 days after inoculation, a few positive reactions are shown on a rabbit skin, but most are negative. Yeah, poor rabbit. So, because one of the forms of diphtheria is skin diphtheria, and here it's shown on biological test. Again, source of infection. By epidemiologic significance, the most dangerous from epidemiologic point of view is bacteria carrier, because he don't know he's sick and he spreads the disease. Then convalescent, and the third place sick person. By intensity, on the first place, of course, is sick person, then convalescent, and then only bacteria carrier. But sick person usually knows that he's sick and stays at home or is bed in a hospital. Sanation of convalescents are completed in 15-20 days, but sometimes up to 19 days. So person already feels normal, but still excretes the bacteria for some period of time. The frequency of carrier state in population 1 to 10%. In 1995, in Russia, we have rather big outbreak of diphtheria, as previously it was mostly in kids. In these years, it was mostly in adults who wasn't vaccinated, and now you see here is the map with rather high incidence in some regions and lower incidence in other regions, and it's up to 150 cases per thousand population in some regions. It's bigger, yes, so in these regions it's rather high, from 18 to 100, and in some regions it's rather low, but still it's covered all the Russia. Mode of transmission, mostly aerogenic mechanism. Corynebacterium diphtheria are spread via respiratory droplets, contact with nasopharyngeal and secretion. Also may be contact and elementary more, less often if some food is contaminated with bacteria, or maybe bed sheets or something like this. Peak of incidence in upper winter period, but entropic in summer period, but it's about skin diphtheria mostly. Periodicity of outbreaks is every 5-7 years. No racial sex predilection. Before immunization was introduced, diphtheria was a primary infection in children, affecting population younger than 12 years. But now diphtheria shifted into the adult population. This trend increases due to incomplete immune status or total inhibition of it, for example, due to alcohol or immunosuppressed drugs. Diphtheria is controllable disease now, but the childhood vaccination of children led to increased morbidity of the disease among the adults. Yeah, he uses the graphic. It's incidence of the cases and vaccination of the adults. Yes, first it grows, but then vaccination is rather high, and the vaccination high and incidence of cases decrease. Inactive vaccination, the incidence has decreased significantly again, what I told previously, and it's data of Russia, but it's similar to other countries. Again, amount of sick person, then vaccination rate. So the higher the vaccination, the lower the incidence. Still maybe some small outbreak, but not as high and when its vaccination was lower. Now, when vaccination is it's about 90% of population, at least 80, 85, 90%, incidence is rather low. And that's what we wait from vaccination. In perfect world, 95% people are vaccinated and incidents are closer to zero. Increased risk for diphtheria infection includes the following factors: incomplete or absent immunization in adult population. In some cases, immunity does not prevent infection, but lessens the severity of the disease. Low public immunity, yes, this is amount of vaccinated people in percentage. Travel to endemic areas with current epidemics. Immunocompromised state. Low socioeconomic status, large-scale population movements, poor healthcare system, infrastructure, and overcrowding. Yes, in Europe, now all attention to COVID, but before this is like 2015 and something like that. Yes, remember, large wave of migration from Middle East came there, and with this migration come some incidents of rubella, of mumps, and of diphtheria too. Because in Europe there are some anti-vaxxers, and these people who came, they may be a carrier of infection, and these two factors meet together, and maybe it's one of the factors why this incidence of cases starts again. Pathogenesis. In place of penetration, mucous membranes of skin, bacteria intensively multiplies and produce exotoxin. That is accompanied by hyperemia, edema and vascular congestion with increased permeability of small blood vessels, and epithelial necrosis. This leads to local damage. Fibrinogen of serum leaves the capillaries, react with thromboplastins of the necrotic epithelium, and transform into insoluble fibrin, diphtheric membrane. So this is simply fibrin. Fibrin tightly holding a fibrinous film on the surface of a mucosa. Membranes increase and thicken up for 5-6 days of illness. Membrane is thick, leathery, gray-white, and composed of bacteria, necrotic epithelium, phagocytes, and fibrin. It is firmly adherent to the underlying tissue. Bleeding follows its forcible removing. Has tendency to extend to another organs, another part, like it may be starting from tonsils and then go to the soft palate, for example. Can detach in 5-6 days. Corynebacterium diphtheria remains under the film, but exotoxin invades the regional lymph nodes and subcutaneous tissue. This causes lymphadenitis and edema of subcutaneous layer and bloodstream, fixes on the target cells with a subsequent toxin and allergic lesion. The other target of the toxins are heart, myocardium and conducting system, nervous system, demyelinization of nerve fibers, paralysis and lesion of the peripheral sympathetic ganglia, adrenal glands, hemorrhagia, tissue necrosis, and kidney symptoms of nephrosis. Again, tonsil cells, tonsils, then myocarditis, nephrosis, polyneuritis. Cord factors of Corynebacterium diphtheria take certain role in pathogenesis of diphtheria, inhibits phosphorylation and tissue respiration. Recovery after the toxic damage is in 4-5 weeks to 6 months if the patient survives. Disease from antitoxic and antibacterial immunity, but short-term. So antibacterial immunity forms, but for short-term. Antitoxic immunity usually lasts longer, but due to antibacterial immunity short-term, disease can repeat. Here is illustration. Again, diphtheria of tonsils. Diphtheria of tonsils plus soft palate, yes, spread diphtheria. Diphtheria of the eye. Again, diphtheria of the larynx, I guess. Classification. For the moment, it's classification with ECD-10. Maybe one day ECD-11 will come. They promise it for next several years. Maybe it's already there. Location of the process: stomatopharyngeal diphtheria, nasal diphtheria, laryngeal diphtheria, cutaneous diphtheria, diphtheria of other localization, for example, nose, diphtheria hypothetical, unspecified. Spreading of process: localized if membranes are localized on the tonsils, on the one anatomic structure. Diffuse if membranes extended in the contiguous region. Combined if membranes localized on different anatomic regions. Degree of severity: bacteria carrier, here with no clinics, subclinical, mild, moderate, severe, and hypertoxic. Character of local inflammation: catarrhal, insole-like island, and membranous. Complication of diphtheria: it may be infectious toxic shock, myocarditis, neuritis, and so on. One of the clinical signs here we see is so-called ball neck. It's edema of the neck during diphtheria. Yes, here and here you can see it. Clinics. Incubation period from 2 to 10 days. Carrier state of Corynebacterium diphtheria, usually asymptomatic, forms after the disease in convalescent carrier or in healthy person 1 to 10% population. No increase in level of anti-diphtheritic bodies in blood. Carrier stage revealed only by bacteriological detection in smears. Carriage of Corynebacterium diphtheria may be short-term, up to 2 weeks, moderate duration 2 to 4 weeks, lingering more than 4 weeks, and chronic more than 6 months. Subclinical form of diphtheria. Patients have no any complaints. Local status: hyperemia of tonsils or pharynx, slight edema, no any membranes. So clinically, any pharyngitis, yes, or tonsillitis, and the access should be confirmed by bacteriological and serological test, because otherwise you can't find any specific clinical manifestation. Sometimes it's revealed late complication, myocarditis and polyneuritis, even in subclinical form. Diphtheria of tonsil in pharynx in mild form of disease. Mild weakness with normal blood pressure. Normal febrile temperature. Local status: hyperemia and edema of tonsils and mucous membranes. Tonsils are covered with spots of gray or white exudates insular form. These spots often form pseudomembranes, membranous form. Increase in slight painful submandibular and cervical lymph nodes. Often confuses with tonsillitis, pharyngitis, acute respiratory viral infections. Diphtheria notice diphtheria here. Yeah? Notice the pseudomembrane in the posterior pharynx. It can become very large and may obstruct the airway. Yes, here it's only in the posterior pharynx. Again, it may spread and block the airway. Moderate severity diphtheria, usually what we discuss, usually what's shown in your clinical task. Moderate severity, acute beginning, fever up to 38 and 5 degree, weakness, pain in muscle and joints, headache, thirst, decreased appetite, pale skin, sometimes acute cyanosis, is all due to severe intoxication. Moderate pain in pharynx and swallowing, it's not latent sign. Relative tachycardia, tendency to hypertension, dull heart sound, systolic murmurs, myocarditis and peripheral neuritis may occur in 2/3 of patients already in this stage. Local status. Edema of tonsils and mucous membrane, cyanotic hyperemia. Pseudomembranes are generally firmly adherent, thick, fibrinous, gray-brown, often extends beyond the margins of the tonsils onto the pillars, palate, or uvula. Removing of them is difficult, followed by bleeding. Membrane doesn't grind between slides and doesn't flow on the surface of water. It's faster that you can do simply while examination. Increased and painful symptomandibular lymph nodes, moderate edema of subcutaneous tissue, regional lymphadenopathy. Plus maybe paralysis of the soft palate as posterior pharyngeal wall. It's one of the early signs of polyneuritis. That's why during tonsillitis we ask person to say ah, and we not only examine tonsils during this time, you also see does uvula moves or not, because if it's not moves, it's sign of paralysis of soft palate. It's really bad sign, and it's one of the clinical signs of diphtheria. Again, here is how it looks like. These membranes. Again, membranes on the tonsils. Edema of anterior neck. Again, edema of the neck. Then severe form of diphtheria. Acute beginning and high febrile fever, headache, myalgia, arthralgia, weakness, vomiting, bad appetite. Cyanosis, signs of dyspnea and early myocarditis, arrhythmia, tachycardia and bradycardia, background sign, dull heart sounds. Peripheral paralysis of the soft palate, cranial neuropathy, myopathy, sometimes hemorrhagic syndrome, kidney disturbance. Local status, enlargement and edematous tonsils, cyanotic hyperemia, tonsils and contiguous regions are covered with thick gray membranes, regional lymphadenopathy, edema of the subcutaneous tissue may be up till clavicles, yes, rather expressed edema. And hypertoxic form of diphtheria, of course, the most dangerous, the most lethal, develops due to penetration of high concentration of bacteria and its highest toxin productivity, starts as severe form of diphtheria, but intoxication always prevails above the local inflammatory manifestation until appearing of membranes, rapid course and early complication, cardiovascular failure, infectious toxic shock, disseminated intravenous coagulation. The patient can die in first 1-3 days. Diagnosis is confirmed by bacteriologic test, but usually post-mortem. Fibrinous film have no time to be generated on the surface of mucosa. So you just see person with high intoxication, with some complication, and you don't even know what to do with him. And probably as a doctor, when you see something like this, you will be treating it with antibiotics. But the treatment here, the main treatment is different. Yes, if you don't know that it is diphtheria, you can prescribe correct treatment. About treatment, we will talk about later. Then, special form, laryngeal diphtheria. It may be as a spreading of tonsil diphtheria or as a separate form. Also, it's called diphtheric group or true group. General intoxication is mild. Larynx is covered with single-layer epithelium. Hypoxia is dominant side in the pathogenesis, upper respiratory obstruction due to membrane. Involvement of the larynx is usually secondary, the result of extension of the diphtheric membranes from the pharynx. Primary laryngeal diphtheria is rare, but still may be. There are three stages of diphtheric true group: dysphonic, catarrhal, stenotic, and asphyxia. Catarrhal stage, continuous 1 to 2 days, begins with febrile temperature, weakness, malaise, cough which becomes barking cough, and hoarseness with sputum. Laryngoscopy reveals hyperemia and edema on the mucus of the larynx and vocal cords and trachea. On this stage, the films on the mucosa are absent. Yes, catarrhal stage only. Laryngostenosis, more often on the second, third day of the illness, duration of the stage several hours to 2-3 days. Appearance of embarrassed breathing and noisy respiration, early symptom. Retraction of accessory muscle and intercostal spaces. Aphonia and soundless cough. The patient is anxious and has forced position in the bed, leaning on hands. Cyanosis of skin and mucus. Tachycardia, tachypnea, reduces blood pressure, dull heart sound. Laryngoscopy reveals edema, hyperemia with cyanosis and pseudomembranes. If the patient does not receive treatment in this stage, he can die. Again, diphtheritic membrane true group. It's due to membranes, while false group, which is maybe in some respiratory infection, more often in parainfluenza. In parainfluenza, false group is sputum, edema, and laryngospasm, plus small small larynx by itself. In diphtheric, in true group, it's due to diphtheric membranes. In forced position in bed, this is how it looks like, and you see additional muscles of breathing also involved. Treatment, usually tracheotomy, because it's mechanical blockage, and just breathing through tube is what you can suggest to the patient. Then next stage, asphyxia, duration about 8 minutes, so it's terminal stage, and that's where tracheotomy only may save life. Fast development of respiratory insufficiency, frequent, shallow, noisy respiratory arrhythmia, total cyanosis, chills, forced position, anxiety, which is followed by drowsiness, weak or endorhythmic pulse, hypotonia, loss of consciousness, convulsion, and death of suffocation without immediate tracheostomy. So this is third stage, and of course it's better when person is diagnosed and treated before this. In adults, asphyxia usually follows on the 5th, 7th day of disease. In kids, on the 3rd day. Diphtheria of nose can be localized or widespread, mild intoxication, local status. Radioscopy reveals edema, hyperemia of mucous membranes on the nasal septum, serosyngenous discharge, irritation of nostril and lips, nasal breezes is impended. Diagnosis is confirmed only by bacteriological test. Like this. Nothing super specific, nothing super special, can be misdiagnosed with some streptococcal infection. Diphtheria of other localization like eyes, skin, or even genital organs is always secondary and includes the purulent and ulcerative conjunctivitis, otitis externa, cutaneous diphtheria, and purulent and ulcerative vulvovaginitis. Diagnosis confirmed visually, injury of the skin of mucus with presence of fibrous film in it, and by bacteriological test. Complication may be two types: Those are a result of spreading of the membrane in the respiratory tract obstruction, and those due to effects of the toxins, that is, infectious toxic shock, disseminated intravenous coagulation, myocarditis early and late, polyneuritis early and late, toxic nephrotic nephritis, and even hepatitis, but only at severe forms. Pneumonia is a specific complication, but also may be present. It's due to activation of secondary bacterial flora, and also asphyxia may be. Laboratory diagnostic. Specific. Microscopy of the smears and its bacteriologic investigation. Swab should be taken from the nose and tonsils beneath the membrane trace and before antibacterial therapy. Then, bacteriologic culture is essential to confirm the diagnosis. Serological test, which show double serum quantity of antibody titer to diphtheria toxin, because even patient who is immunized, when antibody level falls, may be sick, so there may be basic level of antibodies, but they should increase double. Yes. Toxicity test by PCR or ELISA. Non-specific CBC, moderate leukocytosis, increased TSR. Urine analysis. Leukocytosis, erythrocytes, proteinuria, and CAS may be in urine. Biochemical test. AST, yes, in the first place, damage of the heart. LDG, acid-base equilibrium. Electrolytes, serum protein, coagulogram, renal and hepatic enzymes also should be tested. Electrocardiogram, medical consultation of neurologist, cardiologist should be provided. Differential diagnostics. Diphtheria of Staphylococcus should be differential diagnosis with streptococcal and staphylococcal angina, Vincent tonsillitis, infectious mononucleosis, scarlet fever, paratonsillitis or abscess, candidiasis of oral cavity. In staphylococcal and streptococcal angina, covering will be removed without bleeding and rather easily because it's due to some pus and cause different swab. In Vincent tonsillitis is necrotic tonsillitis, so when you remove the covering, it may be bleeding, but its necrosis is removed easily and maybe without high temperature, without expressed pain. Infectious mononucleosis will be additional signs is lymphadenopathy, not only of the lower jaw, but also on the neck, and maybe generalized lymphadenopathy, plus some other sign and some atypical mononuclears in the CBC. Scarlet fever will be with specific rash, scarlatina, scarlet fever. Yes, some specific clinical signs too. Paratonsillitis or abscess usually follows with well, it may be to begin with asymmetria of the when you examine the pharynx, it may be asymmetric, and it's usually painful opening of the jaw. Sometimes person even can't open the jaw by himself, so it's usually a sign of absence of paratonsillitis. And candidiasis, again, different clinics, different swab. Streptococcal and staphylococcal angina, just this bacterial covering, but it will be removing easily. It's just bacterial detritus. Vincent tonsillitis, again, necrosis, but maybe bleeding, but removes easily. And Vincent tonsillitis, also even bacterioscopic examination will be different. It will be with Fusobacterium and spirochetes. Infectious mononucleosis, again, atypical mononuclears in CBC. And oral candidiasis, again, it's also membranes, but it's due to fungi and it's removed rather easily. Ludwig's angina, angioepiponic form of tularemia, secondary angina at typhoid, use, tuberculosis, neoplasm, leukosis, agranulocytosis, combustion of a mucous dermatopharynx, acid and alkaline. Well, more detailed about differential diagnosis, you will talk on the 6th year. You will discuss, we'll have it a separate topic. Diphtheria of the nose, meningococcal nasopharyngitis, streptococcal pharyngitis, adenoviral pharyngitis should be differential diagnosed with. Diphtheria of the larynx should be differential diagnosis with false group, acute respiratory viral diseases, parainfluenza and measles, for example, asphyxia or foreign body, and streptococcal pharyngitis in severe form. Treatment: obligatory hospitalization and bed regimen. Again, you remember that one of the early complications may be myocarditis, and of course, person with myocarditis shouldn't give any load on his heart, so bed regimen is really important. Treatment should be initiated even before confirmatory tests are completed because of the high potential mortality and morbidity. Second is diet. And, well, still the main treatment is specific antitoxin. Yes, the main therapy. And it should be admitted rather fast. The immediate introduction of antitoxin in 1000 IU, it may be intravenous or intramuscular. In mild form, 40 intravenous, 60 intramuscular. In moderate, 80 to 110. Severe, 120 to 160. And hypertoxic, 160 to 220. Antitoxin is administered once at the empiric dose based on the degree of toxicity, site and size of membranes, and duration of illness. Antitoxin should be given intravenous by infusion. Usually second and third administered is not recommended, but it was recommended previously, now it's not true. Still, antitoxic test, allergic test should be provided before antitoxin prescribed, and if it's positive, add hormones, glucocorticoids, to prevent allergic reaction. Antibacterial therapy. Benzylpenicillin, 100,000 to 200,000 EU per kg per day intramuscular. Ampicillin, 50 to 100 milligram per mg per kg per day intramuscular. Amoxicillin, 20 to 25 mg per kg per day per orally. Rifampicin, 9 mg per kg per day, maximum 600 milligrams per orally. Clindamycin, 10 to 25 mg kg per day per orally. Erythromycin, 20 to 30 mg per kg per day per orally. So a wide spectrum of antibiotics may be given, but again, it's secondary, yes, just to prevent further spreading. The main treatment is antitoxin. Without antitoxin, your patient will have more severe course and high risk of death is present. Next, pathogenic therapy. Detoxification and sufficient hydration. Inhibitors of protease, antioxidant, diuretics may be used, glucocorticoids, non-steroid anti-inflammatory drugs, especially in case of myocarditis, antihistamine drugs, treatment of myocarditis neuritis. Prophylaxis. Common prophylaxis. Inspection of the contact person, final disinfection in the focus, quarantine for 7 days. Special. Create anti-active immunity. Vaccination by diphtherial antitoxin, preliminary immunization on the 3rd, 4th, 5th months of life, revaccination in 18 months, and then in 6, 11, 14, and 20 years. The adult population should be vaccinated every 10 years. It's important. Well, that's all about diphtheria. Thank you for your attention. Be healthy and happy.